a little bit off the topic with respect to PECTUS, except as it pertains to trying to systematically decrease the things that give us bad outcomes. So all of us who work in hospitals are aware of the difficulties in making things go the way they should go. Now, I have to say, visiting here in Seoul, where everything runs as perfectly as it could possibly be imagined, I don't know that they need this. But where we are in the U.S., there are a number of things that happen that anyone working in an operating room would like to make better so that our outcomes can be better. And this was an approach that was adopted by our hospital now 3 years ago, and this is to share this experience with other people. So at Children's Hospital of the King's Daughters, we serve all children, whether they're able to pay or not, and we have a large number of patients who are under the Medicaid program, which in the United States provides only a fraction of the cost for taking care of the patients. There are, from a national perspective, a number of things changing in healthcare in the United States, which are encouraging all of us to try to figure out how to make our hospitals work better and to work collaboratively. And that has brought hospital administration together with the medical staff in a way that really hasn't happened previously. So this model is a collaborative alignment strategy to try to identify and prioritize improvements in the operating room in particular by bringing together the administration, the nursing team, the people who work doing things like sterilizing the instruments, the anesthesiologists, and the surgeons to work on common problems. The idea was that the hospital would put up a pool of money which would be distributed to all the participants on the basis of achieving particular goals. And all of this was data-driven. One of the big problems was making sure that we had accurate data. But this model is set up so that there's a committee which I chair, but which has the chief operating officer, the chief nursing officer, the nurse in charge of the operating room, and 60 of the physicians who work in the operating room. 11 pediatric surgical subspecialties are involved, including anesthesiology. To participate, you had to be a significant user of the operating room, so the physicians could only participate if they had done 100 cases in the preceding 12 months. The year was divided into cycles, and during each cycle, a fraction of the physicians participated in these teams, which also had nurses, administrators, and other workers in the hospital. And the idea was that the teams would look at particular problems and then try to make changes on a rapid cycle basis, 2 changes per month. Each team had 2 things that they were to work on, and they came from these 4 groups: quality and patient safety, efficiency, patient experience, and then strategic development. So as an example of the quality and patient safety, to try to diminish infections, there are a bundle of activities that should happen for each patient so that infections are minimized. Patients should get a preoperative bath. They should come to the operating room and get antibiotics administered at a particular time. The skin should be prepared a particular way. The instruments should be handled in a particular way, and so on. Trying to get all of those things done every time for every patient was the charge of that group. And the efficiency and effectiveness, as an example, the group was charged with trying to make sure cases start on time and that the operative schedule, which is the work plan for the operating room, actually fit with what happened, so that if there was one case at 7:30 and then there was another case at 9, that the 7:30 case started at 7:30 and the 9 o'clock case started at 9. It sounds easy, but maybe not so easy. Patient experience was to check and see how happy patients were. For example, when there's a long list of patients, the patients who are not the first case can get unhappy if there's a delay. So we tried to do things to make that better. And in strategic development, we have a system where there's a central hospital and 2 satellite operating rooms The main hospital is oversubscribed. The operating rooms are so busy you can't get in. So we're trying to push the ambulatory cases to the ambulatory centers and trying to work out ways to have that happen. Teams met every 2 weeks, and then there was a check-in every 45 and 90 days. And every 100 days, we changed to a different problem. So this gives an example. In the second year, there were various cycles, and for the first team, which was working at occurrences, so the first of these was to minimize the likelihood of things not being done the way they're supposed to do. So the surgeons are meant to do a brief op note before the patient leaves the operating room. We wanted to get that to 90%, when oddly it was less. We wanted to have the anesthesia providers, 100% of them, using a new tool to look for IV infiltrates. And we wanted to create consistent reporting processes for any occurrences that happen in the anesthesia department, inadvertent extubation, for example. And you can see there are a variety of these things, so that over the first 2 years we were able to tackle 41 different problems. There was a goal set for each of the teams, and if the goal was met, there was a payment which was shared out, and at 100%, patients, if the goal was met, people got 100% of the payment. If it was exceeded 120, and if it was less, they got less or none. So you can see for the cycle 4, cycle 5, and cycle 6 for the second year that we overall did pretty well in terms of meeting the goals. It's not quite that good at the end of year 3, but this has been a good tool for us for trying to help with things. Overall, we felt there were real and meaningful improvements. The overall 12-month rolling surgical site infection rate decreased by 75%. That's a big deal to us. Release time is if you schedule an operation and then you are not able to use it. If you have block time, you're able to use the operating room, but you aren't going to be there because someone's going to be at a medical meeting like this. You need to tell the operating room so somebody else could be posted in there. And people weren't doing that. And that was improved by 10%. The on-time start for the first case increased from 64 to 77%. And there were various things on the efficiency side. For each of the cases, we looked to see if the people doing tonsillectomies, for example, could all agree on equipment, and that decreased the cost per case for supplies. And patient satisfaction scores in terms of updates in the waiting area improved to some extent there. From the administrator standpoint, they want to know how is this financially. So as each project was completed, the return on investment was estimated. The hard savings are things like supply costs, and the soft savings are things which are when you decrease infection rate, you have therefore less need for antibiotics and hospitalization. And the total savings was $2 million, so that the project covered its cost very well. So we felt that this was a good approach to get the people who work in the operating room together to solve problems, and engagement of the practitioners and delivery of the improvement was really very good. It was very heartening to see people come to the front of the room to try to figure out how they could get cases to start on time and so on. So thank you for the opportunity to present this work.